So this session's on endovascular or treatment of the aortic arch, and my topic is endovascular treatment of reality. These are my disclosures. Unfortunately, none of them are financial. And so anybody who wants to give me some money, I'll put your name up here. In today's world, and I'll abdicate to Dr. Caselli and Dr. Provenza, the state of the art is still surgical intervention, and they're going to go through that with you. But what I'm going to try to do is quickly show some of the things that are going on in the endovascular world and where there are limitations and potentially where this is going to go. This is sort of a smattering of devices, and I'll go through them quickly one by one, but it's been an evolution where we have to start with the aortic valve, and after these guys have potentially reconstructed that and given us a landing zone, then really the other issues are dealing and having a stable route to be able to do any of the endovascular work that we're talking about. And normally that size has got to be somewhere under 40, maybe 38 or so for their current devices. The first thing, and actually this device, I think a lot of us have used it now with the initial experience. This isn't moving. With the Gore tag device, one branch that goes into the subclavian artery. And this technology has actually been used quite widely to, I'll show you, stretch it around the arch. So you can not only put it into the subclavian, but if you cover and do some bypasses, you can actually get longer landing zones. This is an angiogram. The device is in the arch. You can see a wire going out the subclavian, and that lines it up then to be able to position this. And this is after the stent, as you can see, has been put into the left subclavian. The challenges with doing this is really getting the right angle where that subclavian branch comes off and being able to dilate it up, because it can be stenotic afterwards. So. But in general, this is a fairly easy use device, and it's been used then, as I mentioned, to be able to go further around the arch. So in this case, if you do a carotid, you do a revascularization in the neck, you can actually bring that across over to the innominate and then be able to reconstruct the arch based on that. So that's one step, and this is the only one that's, I think, widely used that I'll show you. The rest of these are other prototypes. This just shows that iliac branch and where you have to be careful of whether or not that's stenotic or not. Now, you hear a lot of work about snorkels and chimneys, how you can get other grafts into these devices or around it in order to be able to make those branches to the brachiocephalic vessels. And the limitations in these have been really the endoleaks. These are just three of the series that goes in there. And if you look, endoleaks are around 10%. And although the stroke rate can be kept down, it's still not insignificant. This is an example of one of those procedures where you can see the branches that come in from the top, and I'll mention several ways to be able to do this. But in all cases, long-term durability is really the question. There have been several papers now that are out on multi-center analysis of these being able to use what are called the fenestrations in the graft. If you just look at these, they're coming out more rapidly all the time. And this is an example of a patient who's got a PAU in the arch, and if you look, you'll see catheters coming in from the innominate, the carotid, and then the subclavian, with the device being around the arch. What you've got to do at that extent then is poke a hole in the graft, dilate it up somehow. You can do that with the laser fenestrations, and end up with reconstructions that look like this. They can be fairly labor intensive, but if you're skilled with being able to get in from those branches up top and you got a laser or something to poke a hole, you can actually do that. Again, the long-term issue here is durability, because you're poking a hole in a graft, you dilate it up, those fabrics are not meant to seal. And beyond that, then it's, even if you get an initial seal, you can have, as I'll show you, longer recurrence rates. There have been other devices. This is a Japanese device. Stroke rates remain fairly high with this, but the prototype in this case is one of subclavian branch. It's included with a main body that then lets you snare and do the branches to the other brachiocephalic vessels. Endospan, another device, you can see there's an aortic component and then that brachiocephalic component that goes to the innominate or the carotid. There have been reports on this now, and this one actually is progressing fairly to where there are more broad span applications. Again, I mentioned this fenestrated technique because there's a lot of people taking these off the shelf, custom making and making holes to be able to line it up with the branches. But even in that case, if you reinforce those connections, the long-term failures, if you look at it, are the reintervention rates that are related to the having to go back and do stuff later. Other new commercial devices that are being looked at, these from our perspective are primarily in Europe, what's called a double relay branch. These are, as I'll show you in a minute, and these are some of Gustavo Oderich's pictures, but shows you how if you coil that subclavian, do a carotid subclavian bypass, and then have the two-branch option, what you can end up with this is then the arch reconstructed with only having two inner branches. Those inner branches have been developed in a way to get reinforcement, which is the fallback position, is to have these inner branches that actually have a cuff that seals them inside. So that's been the solution for that. Other device, and these are a lot of reports that have come out related to that. Again, the big issue in this case now is the stroke rate. About 8.6 of transient strokes, with hopefully most of those resolving. This is a study, 70 patients had the arch reconstructed. And here's what now is a three-branch prototype, same sort of thing. So the theme continues to develop, and that inner branch secure tunnel that you put the devices into has been the solution to be able to solve that problem. There's, again, multi-center studies that have been looking at this. A lot of access issues potentially because you're now having to come in from several different sites. In the room, and Vinky mentioned this, but when you start doing these from the top and you're working from both right and left arm and even the groins, you have to have the patient prepped in a very versatile room where you're not locking yourself out as you rotate that around. Actually, Stefan Alon, this is a totally percutaneous procedure. If you want to, you can go from the groin, you can go from the arms. Again, the challenges of those access sites, but it's feasible to do. So if you look 5 years down the line, maybe some of these aren't going to be so far-fetched. This is an example of that case at Stefan, and you can see now these inner branches that are the more secure fixation, with this being the picture afterwards. I put this in last night because we had a conversation at dinner about bare metal stents. They don't work in aneurysms, so I'll say that from the get-go, but there are several studies now looking at those in dissections. This one, Arterion, some of you may be familiar. You saw that cuff on. This goes around the arch. These are fairly well-selected patients that they've looked at, but the results are relatively good. The concept being that if you, and like the old cardiatis or now what's in Tressa, if you expand that fully around the arch, and this is a slide I put in just to be controversial, but this is a case Ted Diedrich did in Europe about 15 years ago, an ascending dissection. You can see he put the graft all the way down and actually covered the coronaries without knowing it. This is a 5-year follow-up with everything remaining patent off of that arch, the coronaries. And so, again, these for dissections, if they're fully opposed, they're going to be devices used in the future. So you need centers that have a widespread capability to do these developing endovascular techniques. And again, where we are at the present time, these are all early prototypes, but they'll continue to move as technology and the companies push them along. Thanks.